Company Parek for the exchange of knowledge. Our next speaker is Dr. Prabhu Shanker. He is going to discuss about posterior polar cataract. Over to you, Dr. Prabhu Shanker.
Thanks, Dr. JP and Dr. Jason. Yeah, play. நான் ஆப்ரேட் பண்ணிக்கிட்டுமேங்க. Yeah, posterior polar cataract is the most challenging cases during phaco. So always when you're planning a rexus, don't go try to make a large rexus in case you have a PC rent, you have enough support for the IOL placement. So one basic thing is make a rexus around 5 mm, never hydrodissect. You can hydrodelineate, but even that's too risky. Suppose your hydrodelineation goes wrong, you might end up with hydrodissection. And this is an unedited video, and I'm just showing the patient around maybe 35 years old with a bilateral posterior polar cataract. So very soft nucleus. So I've not done hydrodissection. Since it's a very soft nucleus, I'm just going with very low aspiration. So basically in posterior polar cataract, never allow your anterior chamber to get decompressed. So gently keep aspirating because the very soft nucleus it is, no issues. So I'm just gently trying to nudge the nucleus part. See, very soft cataract, everything is coming down easily. So subvisual nucleus, you have to be very careful. So your second instrument plays a major role during posterior polar cataract, and never allow the eye to get depressed. Now you can see the posterior nucleus coming out very safely. So the most critical step in posterior polar is never come out of the anterior chamber with immediately inject sodium hyaluronate to the side port. This is the basic step you have to follow in a posterior polar cataract, and you will never have a PCR. So always never allow the eye to get decompressed, fill the bag, and now I come out now. So once you come out, it's easier now. So the cortical wash also, same thing, go do the cortex wash. And again, the second step again needs to be followed, go inside again with the second instrument, instead of the second through the side port, inject the sodium hyaluronate. Never try to do any PC polishing, never go near the PC at all, because anytime you can have a PC rent anytime during phaco, during IA, during IOL incision, and even during AC reformation also, sometimes the PC can open because it's a very weak PC. So things are very stable now. And lastly, you can gently place in the IOL. So don't try to exert too much pressure on the posterior capsule, and just you can place a foldable IOL in the back. So surgery is over. It's actually an unedited video. So you just follow the basic principles. Next video. So this is a posterior polar in a soft cataract. Next one, video 2. So this is posterior polar in a hard cataract. Play panel. Okay. So little hard nucleus is quite difficult because chopping will be quite difficult. So it's the same basic principle, never hydrodissect or delineate. But again here the second instrument has a major role, because you'll say once one quadrant of the nucleus is removed, the quadrant under the incision is very difficult to maneuver. So either don't use a chopper, go back to a dialer and try to just disengage that nucleus. Somehow it will start moving around. So just hold on. So don't change much your setting, whichever you do routine phaco, you can do it. So this sub incisional nuclear fragment is the one which is difficult to remove it. So always do all the maneuvers very gently. So once a small fragment is there or epinuclear plate is there, you can just leave it on. Again, the same basic principle has to be followed. Go inside, inject sodium iodide into the anterior chamber, into the bag and come out. So never allow the capsular bag to get decompressed. So once the IA is over, so you don't have to really bother about the hydrodissection. So most of the phaco's, even without hydrodissection, you can proceed, because by the time you just do a chop and start do your maneuver, so it's the same principle. The two principles has to be followed when you're doing posterior polar cataract. Keep always deepening the anterior chamber and the capsular bag. So everything is under control. Third. So this is. So this is the most challenging case now. Posterior polar, posterior capsular dehiscence. The posterior capsule is already opened. So now the challenge, now what to do? Whether you want to do a SICS or a phaco. Play பண்ணுங்க. இல்லையா play ஆகல. இல்லையே இங்க ஒன்றும் மூவ் ஆகலையே. க்ளோஸ் பண்ணி ஓப்பன் பண்ணுங்க. Okay. Now you can see when I decided to do a phaco in this case. You can see the posterior capsule opened under the nucleus, but still I go ahead with the phaco. The only thing is that posterior capsule dehiscence has been there for a long time, so probably the anterior vitreous is already absorbed there, and so lucky I didn't have any drop or PC didn't extend. So again the same maneuvers are followed there. So your settings and all the same settings routinely which you use, so that the anterior chamber is always deep, no collapse. So all the maneuvers are very gently done. So you can see a large capsular opening behind the nucleus. So now again the same basic step is being followed now. Just before removing the phaco probe, I inject sodium hyaluronic into the bag. Okay. So the now once things are very stable, no vitreous, so I could able to place a IOL in the bag. So the basic principles of PPC are never allow the eye to get decompressed. So unlikely to have a PCRNs. Thank you.